Good morning. Today I would like to show you a live case on complex calcified CTO lesion treated by a new microcatheter. This case deals with a patient, a male of 74 years old, diabetes with hypertension that developed last year in December for angina with an exercise test positive and low threshold. So we perform a coronary angio that show a single vessel disease with a mid LAD CTO with a diffuse calcified occlusion. The echo was good with normal V function, and the patient was referred initially to CABG but refused. So the 26th of March of this year, we plan LAD CTO PCI. The idea was to use the Navision microcatheter. Is a new product useful for treatment of CTO PCI. We have two lengths of this microcatheter, and one for antegrade and one for retrograde. He has some interesting feature, and the first one is that the Navision has a very low profile to cross the most challenging lesion. The tip entry profile is 1.76 French, and the crossing profile is 1.8 French. He has also a good hydrophilic coating that can help for the trackability, and is a braid microcatheter. So we cannot spin too much. We can have some small rotation, but not spinning. And we have two different lengths, as I told you before. Then we can start with the presentation of the recording of the case that I performed with my colleague in the Maria Pia Hospital this year. You can see here the right coronary artery, that is the donor vessel. And then with some collateral to the LAD. Then you will see the LAD with this lesion. We have a huge calcification also in the proximal part of the in the open part of the LAD after the first diagonal. We have a very important calcification. Then we will see later how it's important. And then we have an occlusion of the mid of the vessel. We start with the Navitian microcatheter 135. And for us, this was a good test because of the diffuse disease of the vessel, the calcification. So we think that this case was interesting to try to evaluate the performance of this new microcatheter. You can see here, I flash also the external part of the microcatheter in order to activate the coating. This is really important. Then we put the microcatheter with the workhorse wire at the level of the occlusion. You can see here the radiopaque tip part of the micro. And then, as normally I try in a tapered occlusion, I try with a very soft wire. This is a Fielder XTR. Is my first choice wire in when I need a really a small, a soft polymeric wire. Is one of the best wire we can try, but I was not able to cross with this wire. So we can see again the attempt. We try to increase the force also in the microcatheter, but we're not able to cross this occlusion. So we classical step-up approach with Gaia second with the same microcatheter, and then you can see the difference from Fielder XTR and the Gaia. But even if the Gaia second was able to cross the first part of the lesion, was not able this wire to go distally in the true lumen beyond the occlusion, you can see. Because also we need to consider that the diffuse disease of the vessel of the LED. And this is important. So in this stage, I try to advance the Navision in the mid of the CTO body. We have some progress with the Gaia in that stage of the procedure. So with some attempt, was not easy to obtain this step of the procedure, but we have some improvement. And we have an important band at the level of the distal part of the LED. You can see here at the level of the septal. And the Gaia second was not able to go in the LED to overcome this band. So you can see here, I push the Navision a little bit. And then I need to change again the wire in order to have the possibility to go in the big branch in the LED. And so I perform a step down with the previous wire. So with the filter XTR, you can see here the difference between the Gaia and the XTR, because the band at the level of the tip is different from the Gaia. And my previous band was important because helped me to go in the distal of the LED. You can see here. At this level, this stage was important to evaluate also the profile, the trackability of the Navision. You can see here how I was surprised about the performance. You can see without any dilatation, I was able to advance the microcatheter in the distal LED. Then at this stage, the classical changing with the workhorse wire was, I think, was a Sion wire. Then with the trapping balloon, we remove the microcatheter. And we start the classical PCI, so with balloon dilatation, but you will see some problem in with the dilatation because of the important calcification in the proximal part of the LED. So this is the time of the trapping balloon. So removal is very important to remember that always we need to remove microcatheter with the trapping balloon technique. We can have also dedicated trapping balloon, or if you need to have a regular balloon, important to know that with the 7 French guiding catheter, you need to have at least a 2 millimeter balloon. Then we put a wire on the diagonal branch in order to treat the bifurcation. And this is the balloon dilatation. This is a biradial procedure, from right radial to the LED and from left radial to the right. This is the balloon dilatation in the proximal part. You can see here that I was not able to dilate the proximal part of the LED because of the huge calcification. This is non-compliant balloon, a short one. You know that always we need to have a short balloon. Is 3 millimeter and see a 22 atmosphere, but we're not able at all to open that lesion. So we have two possibilities at this level: try to do rotational atherectomy or change it for a shockwave intravascular lithotripsy. We think that for the lesion that you can see, we have a very tight lesion in the proximal AD. Rotational atherectomy would be the ideal situation. And so this is the time which we make first a dilatation of the diagonal branch. That was also calcified. You can see the beginning was not easy to dilate the diagonal also, but in the end we were able to open it. The lesion was really tight, also the level of the diagonal branch. Look at here. This is the first angio. Then again, we change with a non-compliant balloon at the level of the diagonal branch. At the end, we succeed in opening that lesion. Otherwise, we were obliged to use rotational atherectomy in both branches. So 22 atmosphere, we were able to open the diagonal, the proximal diagonal branch. So interestingly, the most calcified part of the lesion of the vessel is proximal. So before the CTO segment. Then after dilating the diagonal, we decide to, as I told you before, to go with for rotational atherectomy. We want to have a single burr, so 175, in my opinion, was the best choice. We know that with 7 French guiding catheter, we can do also with a large lumen. This is a launcher. We can do also 2 millimeter, but we were able to do with 7 French with the 175. This is the final result after stent implantation and the bifurcation. So proximally the left main diagonal, and this was a really good result. We have also a circ very small with diffuse disease. So I think at the end with rotational atherectomy we were able to have a great result at the end of procedure. We can do a little bit some second back to show you again the final result after multiple stents. So from left main to LAD, this is the final result. You can see also the level of mini crash technique at the level of diagonal branch. Just to show you again the excellent result of this complex lesion in this patient. So to conclude, in this complex antegrade CTO case, I was happy about the use of the performance of Navitian 135 microcatheter because it's very good performance in crossing the calcified CTO lesion. So thank you very much.